Hello, my name is Ari Javidan, and I'm the project manager for the National Consortium of Telehealth Resource Centers. Welcome to the latest presentation in the NCTRC webinar series. Today's session is on social determinants of health and value-based pay. And today's webinar is being hosted by the California Telehealth Resource Center. These webinars are designed to provide timely information and demonstrations to support and guide the development of your telehealth programs. Just to provide a little bit of background on the consortium, located throughout the country, there are 12 regional telehealth resource centers and 2 national, one focused on telehealth policy and the other on telehealth technology. Each serve as focal points for advancing the effective use of telehealth and supporting access to telehealth services in rural and underserved communities. Just a few tips before we get started. Your audio has been muted for today's webinar. Please use the Q&A function of the Zoom platform to ask questions. Questions will be answered at the end of the presentation. Please also note that closed captioning is available for today's webinar, and that is located at the bottom of your screen. Today's webinar is also being recorded, and you will be able to access today's and past webinars on the NCTRC YouTube channel. With that, I will pass it over to Aislinn Taylor, Program Specialist at the California Telehealth Resource Center.
Hi, thank you, Aria. I'm Aislinn Taylor. I'm the Program Specialist at the California Telehealth Resource Center. We're thrilled to be hosting today's webinar presentation. Today, I'm thrilled to introduce our guest speaker for today, Ned Mossman. He's the Director of Social and Community Health at OCHIN, our parent company. Ned has spent over 20 years at the intersection of healthcare, research, and IT. In 2014, he joined OCHIN, a nationwide nonprofit health innovation network serving community health centers and critical access hospitals. In his current role, he oversees OCHIN's nationally recognized initiatives around increasing collective understanding of social needs assessment, cross-sector collaboration, health equity, and value-based care. He also plays an active role in a number of national stakeholder groups focused on bridging healthcare and social needs, where he co-chairs the Strategic Advisory Committee. Since 2018, he has served on the board of directors of 211 Info, a nonprofit that helps people identify and navigate social service programs in their communities to address needs such as housing, hunger, childcare, and transportation. Mr. Mossman received a Master of Public Health in Epidemiology and Biostatistics from Oregon Health and Science University in 2002. And with that, I'll pass it over to Ned. Thank you so much for presenting today.
Great, thank you so much for having me. I'm going to go ahead and share my screen. Hopefully the right one comes up. All right, so I am going to talk a little bit about our experience at OCHIN with social determinants of health and really innovating and trying to make social determinants of health something that's integrated into the EHR and part of clinical care and part of value-based payment. And I'm going to do this through a telehealth lens because there's an important impact both that telehealth has enabled this work and that it's really part and parcel of it, both on the data side, on the social needs side. So I'll be sort of speaking to those factors as I go through this. There we go. All right, so just as a reminder, why do we focus on social determinants, or some people call them social drivers of health nowadays, which I kind of like because determinants sounds like it's something you can't change or that it's permanent, but social drivers has a little bit better kind of ring to it. So primarily it's about equity and sustainability, particularly for our health center members, but really across primary care and across all care. So understanding context about patients' lives and providing the opportunity to work upstream to affect factors and improve factors that affect their health, to be able to do population health management. So taking high leverage activities instead of having patients use lower leverage care, being able to do high leverage outreach. So people working to the top of their license doing outreach and often by telehealth modalities and reaching targeted subpopulations for whom they can make the biggest difference. And then understanding areas of need. So just understanding the clinic and the community for your own resource allocation, but also for advocacy and for partnerships potentially to understand, should we partner with a food bank, should we partner with a housing agency, but also to advocate for those things in the community. And then lastly, there is that sustainability component. So understanding and being able to do some basic risk stratification around payment and potentially adjustment acknowledges that more complex patients, not just medically and clinically, but socially complex patients require more resources to care for. So as Iceland mentioned, we are a collaborative at OCHIN made up of over 150 member community health centers and critical access hospitals and health departments and just all sorts of organizations that serve underserved patients by and large. And we also have a research department that has done a number of NIH-funded studies to look at implementing social determinants of health screening and action, and thinking about factors, including telehealth, that both enable that and are affected by that. So some of the findings, the one I really want to point out here is that at the clinic level, adaptability is key to being able to implement screening and action for social needs. And so being successful in dealing with that. And I want you to keep that in mind for a couple of slides, because I'll come back to that. And then other factors, obviously external factors like grants or reimbursement, or even just encouragement from associations that clinics were part of, was a motivator to engage in a success factor. Presence of a strong champion, can't emphasize enough that work with social screening needs to be a driven from the top down, as opposed to something that's done more informally or just at the point of care level without real commitment from leadership. The last 10 years or so, we've seen the increase in connecting social care and healthcare really be something that takes it out of the informal activities that we know our health centers have been working in this space just informally for decades, but really the advancements in the last 10 years or so are all around doing this as something that's an acknowledged activity with the support of leadership. And then lastly, this is sort of common sense, and it goes for a lot of different types of implementation success, but starting small, matching initial activities to whatever that baseline capacity is. And then once you've sort of dialed in the workflows, then scaling it up. That goes for certainly for implementing a telehealth program as well. And then in addition to our research group, we've been able to learn just from the member experience in our collaborative. So we're not prescriptive. We encourage our members to screen using whichever technology or modality or in person or however it works best for them, for their patients and for their communities. And we're really just trying to build a library of emerging best practices. We see a huge diversity in the workflows because our members are highly diverse. And we know there is kind of frustratingly a proliferation of different screening tools out there. And I'll talk about some ways that we've sort of worked around that and sort of made that work across a number of different ways to screen and ways to use that information. And then understanding that team roles and who's doing the screening and how it's being done, both the screening and the outreach, it's again varies widely between clinics. And I'll point out here that both in terms of maintaining access and in terms of being something that's also a social determinant in and of itself, telehealth and access to digital care and digital literacy are all things that are wrapped up in the types of social needs, and especially the poverty-driven social needs that we see and that our members work with. And we know, especially from the pandemic, that access was highly affected. And in fact, across our members, telehealth screening for social determinants grew exponentially. It went from 0, essentially in a month, to over 10,000 screens that were conducted via telehealth for social risk screening in a single month, which is astounding. And that harkens back to that adaptability that I mentioned, where clinics were still acknowledged the need to continue doing social risk screening, and were able to pivot to doing it as they were with much of their work via telehealth, as opposed to those in-person visits that just weren't possible when the pandemic hit. And then you'll see that sort of leveled off and became a bit of a new normal, but the growth hasn't been there until the last couple of months. And so we really see this as an opportunity to help expand screening. You can see that the number of overall screens has been going up throughout our membership, but we really see telehealth as an opportunity for our members to increase their screening activity in a sustainable way. And, you know, I'll say that both in person and via telehealth, specialized screening approaches for some of the sensitive nature of some of the needs that are talked about is beneficial. And so there are numerous trainings out there around empathetic inquiry, motivational interviewing, and we've seen our members use those to some great success in many cases. So if you're wondering about how to train your staff to do these questions, especially via telehealth, where you're not in the same room as the person, to do those screenings in a sensitive manner, those are important approaches to doing that, and I would encourage you to seek those out. I will say, having said that, the research and the surveys that have been conducted on patients who've had telehealth administration of social determinant screenings shows that patients are overwhelmingly satisfied with having their needs screened for and addressed via telehealth, which I would imagine isn't a surprise to this audience. I imagine that that's consistent with other types of telehealth satisfaction as well. And then again, I'll just reiterate that screening for digital access as a social determinant of social driver can help understand what those barriers are and facilitate things like telehealth and being able to use it on a broader spectrum of patients. So I'm going to go a little bit into the data and the use of data, because I mentioned that this is work that our community health center members have been doing for decades, and the thing that's really new is integrating it into clinical workflows. And what's really made that possible is being able to treat this data as other clinical and health-related data, and enabling digital access and digital use of this information. So assessment assistance with social needs. You have to be able to use it in the EHR, and to successfully do that. And of course, that goes especially for telehealth and interoperability that goes across systems as well. So High Tech a while back put out a talk where they talked about these 3 S factors, and I steal this almost every time I do a talk because I really like this way of framing it, and it really describes sort of the different fronts and different approaches that we've had to think about social needs data to be able to exchange it, to be able to use it in the EHR, and to be able to digitally enable the use of this information across things like telehealth, across like cross-sector care coordination. That those 3 S's are structured. Is the data stored not just in free text? Is it something that it's stored in a way where the answers have meaning that can be understood in the EHR? Is it standardized? So are the questions, answers, screening tools consistent across systems? And are there code sets or mappings that represent the data? And are these documented consistently? And then lastly, the one that often gets overlooked is systematically collected. So understanding if only a particular subset of patients was screened has a really big impact when you try and roll up or aggregate that data and make conclusions about it. And then, part of that goes back to understanding the nature of the specialties, the nature of the organizations, the nature of the clinics. Are they receiving only certain kinds of grants to provide care is an example in our members, but are they doing telehealth? Are they serving a particular region or specialty? And again, those are, as you try and aggregate this data and understand it, those are factors that you really need to understand. So just an example of structuring this data is ensuring that anything that indicates an identified need, so a social need that a patient has, which is a quote unquote positive response to screening, is flagged in the AHR, and that declined answers aren't added into a denominator, so that you're not, if a patient doesn't want to answer, you're not assuming either way that there is or is not a need. And then linking referrals to an identified need, problem, or concern that can be documented. This is something we're as we've moved from just trying to document screening to document action on social needs. It's something that we're really wrestling with now, I would say. And then also just considering our granularity about how we categorize the domains, so food, housing, transportation, and whether there are potentially subdomains that we should also be like about housing instability versus homelessness, and housing quality, things like mold, pests, et cetera, et cetera. So really thinking about the granularity of the types of answers. But if this is all done well, it allows you to successfully standardize, because you can roll things up to the level of a diagnosis. And the Gravity project, the HL7 Accelerator project that was started by the Siren group out of the University of California, San Francisco, spun off the Gravity project, which has updated all of the major code sets to include social drivers and social determinants codes, and allowed for mapping of those, and has really worked on interoperability across systems and completed an entire implementation guide of being interoperable with those code sets. I'll also note that as this work has progressed, concept recommendations around social needs have been included and incorporated into the US CDI later versions, which is what the ONC uses ostensibly to certify electronic health record technology. And so they've added social needs assessments, goals, and problems or concerns into those code sets. Importantly, they haven't added outcomes, which is sort of what we'd like to know. But hopefully in later versions, they will include social needs outcomes as well. So there are some challenges ongoing to standardization. I'll note that off the top. Again, I mentioned that list of screening tools that feels like larger every day. CMS has created a list of pre-approved screeners for a couple of their different programs, and that may be sort of a harbinger of things to come. They may use that code set they may use that list of screeners to be the approved list in the future. So you may want to keep an eye on that link and the screeners that are included there. There also has been a lack of progress on CPT, which is the procedures part. So we're getting much better with the diagnosis part, being able to code an identified need, quote unquote Z codes. But being able to code that an assessment was done or a referral was made that's related to that social need is much more of a challenge right now. And that sort of makes it hard to have a denominator that makes sense. If if you know the number of patients who had an identified need, you'd want to know, if you were thinking about a rate of an identified need, who was screened. And so being able to code that effectively is still a little bit of a gap. The other thing is just that this is, so working with, again, through telehealth, through technology, through technology-enabled or assisted platforms across sectors, so from healthcare into social services, is a challenge, because this is relatively new, again, and the infrastructure of the community organizations, we often just refer to them as CBOs, community benefit organizations, but that includes social service agencies, nonprofits, any organization that provides services to address social needs that are identified in screening. And the capacity of those organizations, as you'd expect, is widely varied. Not only their capacity to provide services, but their capacity to engage in electronic or digital coordination of care. And there are a number of platforms that have been popping up to help facilitate that. And I'll talk about that in a little bit. I also want to point out that there has been, in standardization, there's been a lack of evaluation and research around different administration settings. And again, I think this is someplace where telehealth could really shine. And we do need more research to help us understand the benefits and the barriers to doing these screenings via telehealth. But the current evaluation worries more about what the wording of the question was and what needs it identifies, as opposed to saying, is this being administered on a paper questionnaire in the waiting room, or is it being done via telehealth, or is it being done in the exam room via an MA or rooming staff? So really understanding what the difference in benefits of different alternative administration settings are could help us point out some more benefits of telehealth enabled care. So then when it comes to systematic collection, I talked a little bit about how just understanding the different ways this is being done for different types of clinics, for different types of facilities in different regions, and even within a clinic and within an organization, which patients are they focusing on? Are they trying to do that more highly targeted and high leverage outreach that I was talking about? So they're screening patients who are, say, their homeless diabetic population, or are they screening everybody? Are they screening everybody every visit? So something that tries to tie this together a little bit in terms of encouraging systematic collection is measurement. And you can see that there are nationwide examples there through HEDIS for health plans, through the inpatient quality reporting for hospitals, and through outpatient via MIPS, which is it's a voluntary system, unlike the other two. There are now measures for social needs screening. And this is important for systematic collection. It's also important on that sustainability and payment piece, because if there are clinics that have been engaged in this work without a formal path to reimbursement outside of, say, a plan that negotiates this into part of their reimbursement, this isn't something that has had a good avenue to being either measured or compared across care settings and how this work is being done. And again, I think you saw I mentioned that the survey has showed that patients are pleased with the way that being asked these questions over telehealth has worked out for them, as opposed to having to do it in person at the doctor's office. I think there is a real potential to succeed in these measures via telehealth, that again, having these measures will enable us to show. Right now, the two existing measures are around the percentage of patients screened, and then the percentage of patients who have an identified need. But the proposed measures for MIPS in 2024 that they're currently undergoing the rulemaking process, and they may end up in other measure sets as well, also talk about addressing social needs. So not just screening and who had a need, but were they connected to a community service provider, another acronym for CBO is CSP. And then was that need actually resolved? And so what we're seeing is a push towards being able to have an actual measurement cascade. So being able to say who is screened, which of those patients were identified with a need, and which of those patients were connected to a community service appropriately, and then which of those patients had their need actually resolved. And you can see that especially the patient-reported measures that go outside of healthcare, these absolutely will be optimized with telehealth. This is care coordination where you don't need to have somebody come into your office to tell you that they connected with a community service provider. So these are, again, elements that I expect telehealth to have a huge impact on and a huge role in. So, you know, I mentioned at the outset that really it's about equity and sustainability, but it's in that order too. So we really need to ensure that the way that payment models are being engineered or re-engineered these days, that they are covering services that enable both understanding and addressing social determinants of health, but also to account for the cost of doing that. And then building out those quality measures in existing programs to both provide a glide path for that, but also to provide an understanding of how it's working. So part of that, as I said, was that there are those measures at the federal level, but the states in their Medicaid waivers, the states that have had what's called the 1115 waivers passed to allow them to experiment with the way that they're delivering Medicaid at the state level. Almost all of the waivers that have gone through have had an aspect of understanding, addressing, and trying to enable connection to services for various social needs and social drivers of health. So in addition to the waivers here, you can also see that in California, there is a care management payment for CalAIM and in lieu of services for enhanced care management activities that include addressing social drivers. Also, there's a proposed bill that would require health plans, not just Medicaid, but all health plans in California to reimburse for screening and referrals for social needs. And then, you know, I'll say that this is, I already mentioned sort of the federal measurement landscape, but this is, they're increasing their focus as opposed to, they're not done. I guess that's the way I'll say it. So momentum is accelerating at CMS for these quality metrics. In fact, they just, in the New England Journal, a position paper was put out by CMS by their leadership from across different Medicare and Medicaid payment systems. And they really echoed that universal foundational measures for screening and social drivers for positivity and screening, but also for those addressing and resolution of social needs are on their list. And so these are, again, these are things that are being put into, factored into their core set for Medicaid. That's the state level, but also that Medicare and CMS have restated their commitment to being able to measure these. So in other words, there will continue to be more ways to measure all of this. So then touching a little bit more about that evolution into care coordination across health and social services so that addressing these needs becomes easier. We know, again, that primary care and social services have been natural collaborators, but it's been in a more informal way for much of the past decades, although there are plenty of formal partnerships. But data has always been a barrier. And again, this is a place where technology and telehealth can help the exchange of information and data happen in a more formal, organized, and consistent way. But to name the specific challenges with data, getting patient consent, both obtaining it and sharing it with and maintaining and documenting it to demonstrate that the patient has agreed to have their data shared outside of healthcare runs into some of the disparate regulatory and legal frameworks between healthcare and social services and sort of outside organizations that aren't subject to HIPAA. There are differing approaches, standards, technologies. All of this also points to just the gaps in resources. Many community organizations don't have the same resources and level of funding and power that healthcare has. So again, these new approaches are seeking to use technology to bridge the data divide and to enable this collaboration. And there are experiments in several states that have looked at extending telehealth to use it across sectors and to help to build out those partnerships. Really, the nature of those electronic partnerships, they're often referred to as community information exchange as opposed to health information exchange. But they're also called social service resource locators or other acronyms. But they have three really important component services. So the three pieces that they need to have are a directory of community resources that's accessible from the healthcare setting, closed loop referrals. That's sort of the whole idea, is to be able to do this electronically and have the information flow both to the community organization and then back into healthcare, and vice versa when the referrals are coming from social services into healthcare. And then again, I mentioned a really important factor is the ability to document and share patient consent. And then, as I said, the social service resource locators are a platform and a category of platforms. So this is the Unite Us's and the Find Helps of the world that provide a platform that doesn't require the organization on the receiving side to install any special software necessarily. They just are a web-based platform that they can use to help sort of manage that care coordination across sectors and to inform others in the community and others who are involved in the patient's care about the services provided and the patient's status. And then there are also other initiatives like 211s in many states and regions. So often they provide the resource directory data that's used by those SSRL platforms. And these types of arrangements, part of the strength is obviously in being able to connect patients to resources directly, but another part of that, it goes back to the data and being able to provide important data on needs in the community for capacity building and for resource allocation and advocacy. And again, I'll reiterate that these all can incorporate telehealth-enabled care coordination efforts, and that's a strength, is being able to do this via telehealth as opposed to doing it through in-office visits. And then, of course, there are other challenges. So engagement, I touched on this earlier, engagement by the community organizations. Their infrastructures and capabilities are widely varied, more so even than in healthcare. Many of them actually don't do care coordination in the way that we think of it in healthcare. A food bank that focuses on handing out box of foods isn't necessarily going to want to log into a web platform every time that it hands out a box of food. I'll also point out that honestly, the trust in the healthcare sector often is low at community organizations, and understandably because many of them have been burned in the past, where they created a partnership where they took on clients from healthcare settings that were sent to them from healthcare settings, and they weren't provided with any resources or capacity building activity to help support that. And then, of course, part of that fits into the quote unquote medicalization effort, or perceived medicalization towards the CBO's work. And all of that is, of course, to say that they're not, oftentimes they're not engaged as true partners, but as sort of an outside provider that isn't included in planning or resource sharing or those kind of efforts. So I think I've covered the privacy and consent. And then the last thing I wanted to touch on was that patient trust really is essential in being having their care coordinated across these different sectors. So going from place to place, things like a referral to nowhere where they're just handed a list of resources, or a phone call is made and then no follow-up happens, really can harm that trust and make patients reluctant to engage in this type of coordination in the future. And telehealth can really help that. It can also harm that if it's not done in a way, again, that sort of focuses on the patient's needs and focuses on and their needs, their wants, their agency, and their ability to make their choices for themselves. So that's with that, I'll just leave this list of resources for you here. I know the slides will be shared, and I'll turn it back over to Iceland. And thank you very much for your time.
Thank you, Ned. That was so great. It's so helpful for me to hear about these measures and understand more of these initiatives and where they intersect. So thank you so much for this great presentation. I want to encourage the participants, any attendees, if you have questions for Ned, and now is your time. So please enter any questions you have using the Q&A feature on the bottom of the screen. We'll give it a few minutes for some to come in. And while we're waiting for some questions, I just want to give a quick kind of shout out for some upcoming events from CTRC. We're having an interactive telehealth workshop next week, tips and strategies for telehealth program success. It will be virtual, but unlike this webinar, we're going to ask you to come on camera and be ready to interact with us next week. And we're also having an annual summit in June. So I'll share those links in the chat if anybody's interested in continuing their telehealth education. These are geared towards the California region, but we're open to all. Yeah, and I am seeing just some thank you for some great presentations coming in. So shout out to Ned for a great educational session. We'll give it a few more minutes for some questions to come through. Yeah, please drop your questions. So there in the chat, I am dropping registration for our upcoming events. So Ned, to say thank you, excellent ideas and programs. Also great to reference is the imperative to follow up on patient needs shared. Thank yous. People are going to share this presentation with their colleagues. Excellent presentation, great feedback. That's always nice to hear. I think we covered a lot of information in the session. So yeah, I think people are happy to have this education and digest this content. One question I have for you is, the features of care coordination across health and social services are really more barriers than features. How can you better facilitate such coordination?
Yeah, so you're right. There probably are more barriers than features, but we know this has been done, again, in many ways informally in the past. So how do we make this work better than just picking up the phone and making a phone call, or handing the patient a list of resources? As we kind of mentioned, there's a referral nowhere idea that that is not great, not good patient experience, not good patient care, doesn't help anybody. And I would suggest technology. Telehealth has a big role to play to be able to enable this. And again, there are those platforms that have sort of popped up and are providing a means to do this without, a social service organization having to install something on their end and track another system. And these are meant to be community-wide, so it's not like they would have to implement one's, a housing agency wouldn't have to enter something in a bunch of different systems, like in one system for every healthcare provider that they work with, but having one system as the central place to do this is really important.
Great, yeah, definitely agree. One system makes it a lot easier. Next question, can you speak more to using this data for value-based payments?
Yeah, so great question. And so you have to be careful about adjustment. So part of our research right now is focused on how to effectively adjust. CMS is very interested in this. They're already sort of looking at adding social components to things like HCC, although it's not there yet, but there are indices and means to do that. The challenge is we don't want to create a two-tiered system where if you have socially complex patients who have a lot of social needs, you're sort of treating them one way, and if you don't, you're treated another way, or scored or assessed another way on your clinical outcomes. But just understanding that if you have a high, just as an example, if you provide care for a large number of homeless individuals, just the data would show that they are more expensive and more complex to care for. They have more complex needs, and so that has to be accounted for in the reimbursement.
We have two questions asking about the same. How can we get health plans to help with social determinants of health closed loop referrals?
So some health plans have already made investments in helping actually to establish networks of those like social service resource locators. Some health plans have been very forward thinking about this. Others, it's not on their radar. And I think it's, if I had a large number of patients with social needs that I was taking care of, I would bring it up in contracting and say, look, this is a cheap investment you can make. I think for if they're willing to look beyond if they're willing to play the long game and think about ROI in terms of both outcomes and ultimately in reducing costs, because it's again, this is triple, quadruple aim stuff where you're providing better patient care and reducing things like readmission and you're helping address people's most basic needs, and that's again doing that upstream of the things that the healthcare effects of those social needs.
Yeah.
So I would it's a conversation I would have at contracting.
Yeah, agree. Definitely keeping that conversation going, and exactly what you said, the long-term return on investment is so key to that conversation. Our next question is from Leona asking, what are some ways that we can let community organizations know about these referral programs?
Yeah, so that, like I said, a lot of them are community-based, where a single solution comes up in a community. So it's a Unitas platform that the hospitals and the clinics and the community organizations agree to use. What I would say is that ideally, it's not just a matter of letting them know, it's a matter of involving them in the planning. And so as these factors as these platforms are launched and networks are launched at the community level, ideally you're bringing the community organizations to the table too and building true partnerships, because that engenders trust a lot more than later when you have to go to them and say, hey, can you please use this platform for the quote unquote privilege of taking more of our patients and providing services, even if you may not have capacity. So the more you can involve them in the decision making collectively. It's hard if you're a clinic that's smaller or an organization and you weren't part of those decisions, though. it's tough. I think I would love to see like a manual for being a good healthcare partner for social service. I think one of the things that chapter 1 would say would be how do you help them build capacity according to the patients that you're sending their way. So for every patient that you send a community organization, how are you ensuring that they have the capacity? How are you truly partnering with them? So
yeah, great tips and considerations. Right, we have one more question. So if there's any more, please, now's your time to please submit. Last question for now is caring for more extreme high-risk patients. What is the best way to make sure CMS pays for the care of these patients? Coding, documentation, contracts, or both?
Yeah, all the above for sure. So in your existing, contracts, making sure that you're availing yourself of what's in that contract by, community health centers, just our members, I will say, have historically undercoded the work that they've done. Part of the importance of standardizing the terminology for social needs is being able to document it and it goes exactly to your point, which, I think maximizing what you're actually able to demonstrate to CMS and other payers as well is hugely important. And then that gives you, when it comes to that next contract time, it gives you the information you need to say, here's how my rates should be set. Here's how, here's how we need to be paid to take care of these patients. So there are also specific programs, like in California, there's I mentioned the CalAIMS and the enhanced care management rather. So that those sorts of programs are out there, and again, you need to be able to demonstrate that you're following those programs. So coding and documentation are still very important.
Yeah, so vital. Well, that's all the questions I'm seeing. Oh, wait, we got one more. Last one. How can we help get caretaker and case manager buy-in on responding? We're discovering that there's a bottleneck with case managers for clients who may not be able to fill out forms and have communication issues when it comes to getting this information.
Oh, that's a great question, and it's tough. So we know from our research that our membership in California, our members lost on average 30% of their non-clinical staff during the course of the pandemic. So as they're rehiring up in the wake of that, as they're trying to bring their staffing levels up to where they need to be, the opportunity there is to think about what your staff needs to look like. Do you need more care coordinators? Is that a place you can focus on? And I know that that's that's a frequent bottleneck.
Yeah,
it's hard to, in a patient-centric manner, be able to help patients who have such vastly different needs. So I sympathize. I don't have a perfect answer other than to say, thinking about being able to staff in ways that give a little bit more flexibility and a little bit more time for those care coordinators to do that work, because there's just no substitute for being able to have a conversation with a patient who has complex needs and maybe there's language barriers, maybe there's digital literacy barriers, especially in telehealth. Maybe there is a challenge with using the tools that you have. So again, being able to staff folks who can take the time in a way so folks can take the time to do that work is important.
Yeah, it really is. I know for us, we do hear quite frequently the staffing issues. And so that's something CTRC does have resources for looking at what staff roles are suited for your telehealth program. And always trying to optimize staff time. I'm not seeing any more questions at this time. So I think we're nearing the end. So I just want to thank you, Ned, for presenting on behalf of CTRC. We really appreciate it. Yeah. I'll hand it to Arya.
My pleasure. Thanks.
Thank you, Aislinn, and thank you again, Ned, for your presentation. I'm just going to bring up our closing slides here. Just a reminder that our next webinar will be held on Thursday, May 11th. That has been rescheduled from our regular third Thursday schedule. That will be hosted by the Northwest Regional Telehealth Resource Center, and that will be on Tap into Telehealth, Innovative Models of Telehealth Access Points. Registration information is available on the NCTRC events page. And lastly, we do ask that you take a few short minutes to complete the survey that will pop up at the conclusion of this webinar. Your feedback is very valuable to us. Thank you again to the California Telehealth Resource Center for hosting today's webinar, and have a great day, everyone.
Thank you.